Good afternoon. I'm Suzanne O'Brien. I'm a hospice nurse and an end-of-life advocate. I am working for hospice at this time. I want to talk to you today about end-of-life care and how you can achieve end-of-life in comfort and dignity and on your own terms. I've seen firsthand how, as a community, we do not talk or embrace the subject or death and dying. And I've seen as a nurse how the medical profession and the healthcare community in general tend to sustain life to the very end. And the difference that having an advance directive can make with your end-of-life experience. It can be the difference between having a comfortable ending at home or one that is in the hospital filled with maybe procedures that you don't really want. I'm here to discuss your options, and I'm here to tell you how you cannot get caught up in prolonged treatment by doctors who get caught in the middle. Doctors are caught in the middle of what is humane, of what patients truly want, and what is considered best practice for end of life in today's society. So what is an advance directive? An advance directive is a legal document that allows you to make your end-of-life decisions ahead of time. It consists of two different forms. One is a living will. A living will says just that. While I'm able to make decisions for myself, I'm going to say what I would want, or more importantly, what I would not want at the end of life. For example, hydration, a feeding tube, keeping alive prolonged with transfusions. That's something that a lot of people do not want at the end of life, but if their wishes are not put in writing, they're going to go into default mode, and that's going to be what happens. The other document is a healthcare proxy. A healthcare proxy is actually naming someone to speak for you if you're not able to speak for yourself. So that's what an advance directive is. Now, with that said, if you found out that you were having a life-limiting illness, how many of you would want to be kept at home? Okay, I'm going to raise my hand too because it's really important. And you're not unlike the 9 out of 10 people that were polled by the National Hospice Organization. In 1996, they did a poll, and 9 out of 10 people said they wanted to be cared for at home if they had a life-limiting illness. Yet, statistically, half of the people today are dying in the hospital. So we have to look at why. Now, with that question, how many of you do have an advance directive or somehow have your wishes stated in writing? Excellent. That is very good. Okay. In America, 1 out of 4 adults has their advance directive in place. Of those 1 out of 4, half of them know where it is. So it's not something that we really commonly do as practice in our country. So we want to talk about why we don't address end-of-life care. I think the answer comes from we're afraid to talk about death as society. You know, I've been at the bedside of people and I'm caring for people. The reason that I'm here in front of you is because of my experience. When I'm caring for someone at the end of life and they're told that there's no more curative measures, everyone sort of goes in a tailspin. And I'm saying to myself, why as a society that is so advanced in so many other ways are we having this end-of-life dysfunction? End of life is very hard. You love your loved ones. If you don't have advanced care planning in place, it makes it 100 times harder. My patients, about 9 of them out of 10, would take my hand, very weak in a hospital, whisper to me and say, I don't want any of this care. I want to go home. But in the other room, the family and the doctors are on this treadmill. What can we do next? What are we going to do? Families fighting amongst each other. Some say let the patient be calm and go. Some say no, we need another surgery. And the doctor's caught in the middle. The medical profession is trained to treat and keep people alive. And that's just what we do in today's society. Only 4 of the medical schools actually have end-of-life training. And that means not towards the end of life. It means that now you have no aggressive treatment that's going to help cure your disease process. How do you care for somebody who is terminal? How do we not have training like that? How do we just focus on sustaining? So the doctors don't want to bring it up. Society in general doesn't talk about it, and it turns into a very complicated issue. Now, if you're looking at end of life, you want to talk about the quality of life. That's something that's very important. When a patient is at the end and they're being treated, maybe a surgery, the Lancet in 2011 did a story. A third of older people in their last year of life, 1/3 were hospitalized for surgery. It's pretty major. Some during the last few months, some even the last week. If anyone has had a surgery or knows what it's like to recover from that, is a very hard course to endure. Older people are already compromised, so then sometimes at the end they're having their surgeries and they die anyway. The quality of life that I'm talking about, if something is not going to help a person, why don't we talk about palliative care? Hospice and palliative care kind of go hand in hand. Palliative care is comfort care. It's managing symptoms. If I cannot cure, and people have many chronic diseases today, if I cannot figure out a cure for your disease, how about I manage your symptom? For instance, if you have congestive heart failure, that's something that can be very difficult to live with. Your heart is just not pumping, your breathing is compromised, but if I can look at you and I can manage your symptoms and bring your quality of life to the highest level by allowing you to have the maximum air exchange, by pacing your activities, by, if you have chronic pain, taking care of that, well, guess what? Your level of living goes up quite high. If you have chronic pain, you're going to have nausea with that. You're also going to be a little grumpy, and that's okay. If I can take your pain and manage it to a certain level, you're not nauseous anymore, you start eating, you have energy, and the quality of life, you can enjoy the time with your loved one. It's very important. The other thing about the medical profession, and that when we sustain life, we have to look at, are there economic incentives involved right now? It's something we can't ignore. Financially, is there gain in end-of-life care? And unfortunately, there might be. The Wall Street Journal did a story, and it was entitled, "The Crushing Cost of Care." It did a study, and it said 96% of Medicare patients, the hospitalized Medicare patients in the last year of life, were the elderly. 22% out of them died in that last year of life. They said we cannot ignore the fact that we're treating elders without objective concentration on the quality of their life and cost. The same article had a gentleman who was younger in age. However, he had an unprecedented $2.7 million of incurred Medicare care costs in the last year of his life. Now, this young man had a heart transplant. He then had a leg amputation, dialysis, and finally clinging to a respirator for his life. He could only mouth the words, "Help me." He ended up dying. One doctor very close to the case said, we cannot ignore the fact that we did not look objectively at this man's quality of life. We're doing something wrong, we're focusing wrong. Now, ironically enough, doctors who are faced with end of life take the different track. And this is statistically the same as well. They know the limits of medicine and they have all the available treatment that they could want. But somehow they opt out of heroic measures. There's a doctor named Charlie. He was diagnosed with pancreatic cancer by one of the top surgeons in the country. This surgeon had developed a procedure that could increase his survival rate of 5 years from 5 to 15%. However, he would have a very, very poor quality of life. Charlie, knowing the limits of medicine, shut his practice, went home the next day, no treatment, no chemotherapy, no radiation, no surgical intervention. A few months later, he did die. He spent time with his family, and a few months later, he died. But Medicare had not spent a lot on Charlie. Dr. Ken Murray, who wrote this article for the Wall Street Journal, said, "My doctor has my own wishes in writing, and there will be no heroic measures. That when my time comes, I will go gently and serenely into the good night, like so many of my fellow doctors." Now, I just have to say that we have to look at why we're maybe presenting to society, and I do think it's because we don't have our wishes in writing, we haven't spelled it out, and doctors get caught in the middle. I know being at the bedside of patients, when a doctor comes in on his rounds, he's got about 10 minutes. It's very hard these days being in the medical profession. If society has not addressed the fact of end of life, we haven't talked about it, and a patient doesn't have their wishes in writing, in that 5 minutes of that consultation or whatever he's going to say, is he going to sit down and open up the fact that this patient's dying? He'll need at least an hour for that. Because of the fact that we don't address it in general in society, it opens up a whole can of worms. I've seen the most intelligent of people, and they love their loved ones. I know you loved your loved ones. That's why I'm here in front of you talking about this. Say the word dying, and emotions run wild. Nobody can make a clear-cut decision, and guess what? The patient in the bed is the healthiest in the room. She and I, or he and I, will look at each other, kind of do a little wink, allow for this to pass, but it's not a good scenario. And they don't know what to say to the patient. They're in their shock mode. They're in their crisis mode. And all this patient really wants to do is go home and have some quality time. It's inevitable that we will face the end of our life. If somebody knows any different, let me know. But it's just a natural part of our life's journey. So to make sure that we ensure that our wishes are made known is really important. Love for your family, and I know you love your family, is doing what they would want for end-of-life care, not what we would want. There's a big difference. You know, this could lead to family strife. We know the case of Terry Schiavo, the woman who was in a coma for 7 years in Florida because there was no advance directive. You know, that was a heartbreaking story, but it was a cautionary tale, and we have to learn from that. She was a young woman, and I have to say, I mean, even, you know, when you're young, you just don't really want to address that. We do address wills, though. We will make plans for dying for our material possessions. However, the most valuable possession we have is our own life. Why not put in writing what we would want or what we wouldn't want for advanced care? The New York Times also did a story that advanced care planning reduces stress on patients, on family members, and healthcare providers. And it also helps at the end that you don't have complicated grief from losing a loved one. It's a win-win situation. Okay, so there's two forms, like I said, an advanced directive. It's very easy to find. There are two separate forms. There's two easy websites that I'm going to recommend to go to. One is the Department of Health. God bless you. In New York State, the Department of Health, you click on forms and you can put in advanced directives, and it's a one-page print. Do it. The other one is the www.aarp, and I like that one a little bit better because it does explain to you about what the forms are. Very proactive, talking to you about your choices. Okay, so with all that said, and I know it's an uncomfortable topic, you have your advance directive, but you have to have the discussion with your family. You have to sit down. Fear is paralyzing. We're afraid of this topic. Me too, a little bit, but not anymore, thank goodness. You sit down and you talk about it with your family. Once you open up that topic, guess what? It takes that fear component out of it. Some really good work can be done. Now, I know we had to talk to our kids, have the sex talk, and that was uncomfortable. This is the same thing with your parents and your loved one. It's an uncomfortable topic to address, but it's extremely necessary. So I hope I've convinced you that it's a really good thing to do, to be proactive and to get it done. I want to tell you there's a reason that I'm standing here before you. I've worked in acute oncology. I've been at the bedside in the medical center where people are coming in, and unfortunately a lot of them are dying that way without wanting to. I don't have a difference. If you want everything like my mom, if she wants the whole 9 yards, God bless her, I'm going to do that for her. I'm going to follow her wishes. My dad wants nothing. The point is that I found from being at the bedside that most people were being treated prolonged and aggressively and didn't want it, were too weak, and couldn't state for themselves because the family was in the middle of turmoil what they wanted. That's not how we should have end of life. I know you love your families, and this is something that we can do to help them achieve a peaceful ending. So I urge you to protect your rights to choose the best ending for you. Thank you.
Question?
Yes. Okay, yes.
Suzanne,
Yeah.
these, the living will and the advance directive, they, I assume, should be in the possession of your loved ones.
Correct.
Now,
Yes.
you make copies of,
Yes.
what is the mechanism to ensure that they will be found and followed?
Great question. More rather than not, you should have one. Obviously, your healthcare proxy who you choose should have one. Your family should have one. Your practitioner should have one. And if you have an attorney, they should have one on file too. The most important thing is that it's accessible. Let's say, for instance, that you had to go into the hospital, that you know where it can be located. Okay, so a couple of copies is really helpful too. Again, we said that half the people who have them don't know where they are because they did them. And the other thing that's really important to note is that at any time you can change what's written on there. These are not set in stone. We all change our minds. How many times do we change our careers in our lifetimes? If you decide something today, it can be changed at any time. So don't be afraid to do it because you think that once it's down there, that's your only option. Very good question. Yes.
There's a gap in that comes in, and my mother died at the age of 90 and a half. At the age of 90, on her birthday, she had a heart attack. Was in an assisted living facility. The assisted living facility had a DNR or whatever, like no treatment if something like this comes up. The hospital should have had it from the assisted living facility. Unfortunately, the night crew at the that found my mother called EMS immediately. They didn't have it available to them at the moment. The EMS team didn't have it available to them at the moment. They took her to the hospital. They did all sorts of stuff that she did not want to have done.
Right.
They got done anyway because nobody could, at the moment,
Right.
at 2 o'clock in the morning, come up with these documents. So what are the odds of them ever being able to come up at the right time with the right documents?
You said that your mom was in a facility at the time, correct? I have to say then that is a problem with the facility because somebody should have an indication, especially when they're in a home, that says, okay, where do we look? We know that there's an older group of people that are already compromised that are in a home. Where do we look to say what their wishes are? It should be right available, a no-brainer. So I do have to say that we have to work harder in healthcare to make sure that doesn't happen because that's not okay that your mom had to go through that, period. And the DNR was in place. So I'm very sorry that, that you had to experience that, your mom had to experience that. But again, that should have been a clear cut somewhere in her room on a wristband. It's usually on a wristband sometimes when you're in a facility that you can say, okay, is this patient, she's nice, God bless her heart, that's wonderful. But, are we going to do those kind of measures and pound on her chest? No. So thank you for sharing that. We have a ways to go.
These forms need to be notarized.
They do not. Very good question as well. These forms are legal documents. They need to be witnessed, but they don't have to be notarized. They're very user-friendly. They're one page, if that. You can fill them out. They have, and that's why I said the website of WAIRP is very good because it kind of explains it. You do have to have a witness, and I want to say that if you let your family know, if you have this discussion, all these kind of questions can be opened up. There's no guessing work. So they don't have to be notarized, and they are legal. Know where they are. Okay. Anyone else? Thank you so much. You've been great. Thank you.
For you.
Thank you very much.
Did you want to introduce your sidekick who came with you?
I do. This is Emily Collins from Bang & Collins PR. They're phenomenal. If you ever need anyone to do work for you, I can't say enough good things about it. I know. Thank you.
I'm going to give her a pen.
Oh,
too.
thank you. You get a pen too.
And then your final thing,
Okay.
you pick your ticket. Or, not your ticket.
Not
but
mine,
you can
per
pick
se.
your ticket.
Wow. Okay, ready? The number is 553634. Anyone?
Okay, it's my pleasure to introduce Suzanne O'Brien, who I've had the pleasure of knowing for umpteen years. She worked as a nurse with my wife for many years, and she's branched out and now is involved with hospice. And so I'm not going to say a whole lot more because I forgot what she told me to say. But that reason, at this age. But anyway, she's a great gal, and she's going to make a presentation.
Okay, thank you so much, Fred. Thank you, everyone. So as Fred said, I am a nurse, and I've had wonderful thing about nursing is that you can do so many different things. I mean, all with the intention of helping people. That's why you go into the field. So my journey has brought me to be a hospice nurse at this time. And I'll talk a little bit about how I became a hospice nurse. But the first thing I want to say is, I have a question for you. How many of you have had a conversation about your own death or the end of your life with your family? Excellent. That's great. It's not a very common topic of conversation, but it really should be. So during my time as a nurse, it has become really apparent to me that as a society in general, we don't talk about death or dying. It's like something quiet in the closet. And then also, there's very little accurate information that I found out that people know about their options and what hospice care is. So that's what led me to where I presently stand before you as a hospice nurse. It's inevitable that all of us are one day going to face the end of our lives. We know that. That's part of our journey. That's part of the deal. The difference is how you experience it. And hospice can help. So what I want you to know is that you do have options, and I'm going to explain what they are and how to ensure them. What is hospice? The hospice is a model, and I love that word. It's a model of care holistically. What does that mean? It means that it deals with the whole person, holistic whole. I'm a nurse, and if you have pain, if you were sick from cancer and had pain, I could give you a medicine, a narcotic, to take care of that pain. But what about the pain that's here and that's here? You know that you're sick, and sometimes, especially on hospice, it's at the end of your life. We know that there's not a cure. I want to treat your whole person. And I do that with an interdisciplinary team. Hospice has a team that kind of swoops in. You know, you come on hospice, and unfortunately, it was polled, and 7 out of 10 people said they were referred to hospice too late. And that's something, again, that we're going to talk about. That's why this is an education piece to get it out there. Hospice is from a prognosis of 6 months or less of your life, but people tend to come on for 2 months, sometimes a few days. So this team, you get admitted, this team comes in, and who are these people? Well, there's a nurse, and I'm going to come in and I'm going to medically look at you and take care of your symptoms in your body. But there's a social worker, there's spiritual care, there's music therapy, there's pet therapy. So all these people come in, and there's also home health aides. When you're caring for somebody at the end of life, there's a lot of physicality. Stress, yes, and also the physicality of it. We want to come in, we want people to be in their home because most people do want to be in their homes. We want to take the stress out of this experience and let you be present with your loved one at home. Now, the Hospice Organization did a poll in 1996 nationally. 88% of the people polled said that if they had a terminal illness, they want to be cared for at home. I'm part of that, by the way. Yet statistically, half of people are still dying in the hospital. So now, in 2003, I graduated from Dutchess Community College, and I went into nursing right away. I went to Northern Dutchess, which was fantastic. I found my way to the OR, which was great. And then I went to hospice. I always had a very comfortable feeling with end of life, so I knew that that's probably where I needed to be. I went to hospice, but then I decided to be a better practitioner in hospice. I needed to find out what people go through before they get to hospice. What are we doing as a medical profession? How are we doing it as a society for people who are diagnosed with terminal illness or severe illness? So I went to work in acute oncology. And I have to tell you, at that time, I was absolutely blown away by the lack of information and options that people were given and how little people knew about hospice care. I would have people in their beds, wonderful, amazing individuals at the end of their life, take me by my hand and say, I want to go home. I don't want to be here. I had a woman named Margaret a couple of weeks into my first rotation on the unit. This woman was 76 years old. She was having chemotherapy to help her cancer. Sweetest woman. She had now, unfortunately, chemotherapy has a list, a mile long, of side effects, and that's part of the deal. It kills the good, but it kills the bad, hopefully. So she was having some GI trouble, and she had to keep going to the bathroom. And she rang the bell to me, and she was profusely apologizing to me. She was embarrassed, and she said, I'm sorry, I got to go to the bathroom again. I don't know why this is happening to me. And I said to her, didn't your doctor tell you that this was a side effect? And she said, no, I would have never wanted this. And right then and there, I said, wait a minute. Hold on. It is absolutely fine if you want treatment. If you want everything, that's not the point that I'm making. The point is, I found that people weren't getting the information. A big problem was that if we don't talk about it as a society, and I'm going to just say this in general, if I come to you and I say, as a doctor or practitioner, that, looking at all the tests, that it looks like this is, where we're at, we haven't talked about it ahead of time. Guess what? Shock mode comes in. When shock mode comes in, you don't hear, you can't make rational decisions, and it makes it very complicated at the end. So that's where my work began. So I said to myself, okay, where are our problems? Our problems are, number one, our medical profession at this point, unfortunately, is trained to sustain life to the very end. There's only 4 medical schools that have any end-of-life training. I'm not talking about training towards the end of life. I'm saying you're at the end of life. How do I care for you at the end of life? It's different than I can keep somebody alive very easily with transfusions, with oxygen, with whatever means, but keeping somebody alive and living are 2 entirely different things. Thank you. So what I want to say is, now why are we doing that, and what is the point? And if I found that most people were okay and that's what they wanted, but the fact that they weren't okay, and also the families, I know that we love our loved ones. So to see the suffering be 100 times harder for the family and for the patient, it was not acceptable. So I said, okay, where does our work go? What we have to do is we have to open up the discussion. It has to be okay. We're scared of the talk, yet it's something so natural that we're going to experience. We have to, I always say, you talk to your kids, you have that sex talk at a certain point. Do you want to do it? Not really, but is it necessary? Absolutely. This is the same thing. We have to sit down with our loved ones, with our parents. I happen to do it with my child already because he knows where I work. It's an uncomfortable topic, but guess what? You start talking about something that's been in the closet, and all of a sudden that fear component, oh, wait a minute, you know what? That's not so scary. And it's empowering because you're going to decide what you want. My mom, God bless her heart, she wants the whole 9 yards, and that's perfectly fine. My dad, he doesn't want anything, and that's fine too. Do I agree with, it's about what they want. The most loving thing you can do for your loved ones, number one, is not put the burden on them to decide. They won't agree, by the way. I've had so many people fighting outside a patient's room, and the patient hears it. It's not okay to put that, and they're trying their best. One says, yes, they want to have the surgery for mom. One says, let her go in peace. This is the last opportunity you're going to have with a loved one. You don't want it to be full of strife. Everyone knows the case of Terry Schiavo. She was in a coma for 7 years because there was no healthcare proxy. The family was fighting. That's not how we want end of life to be. So, like I said, if my mom wants everything, if my dad wants nothing, it's a no-brainer. It's on paper. So all I'm going to do is support their wishes. So what I'm saying to you is to do an advance directive. An advance directive is a legal document. It consists of 2 forms. One is a living will, which states what you want or what you don't want for end-of-life care. It's very simple. The other is a healthcare proxy, and that's going to be the person you assign to speak for you if you can't speak for yourself. Okay. You can get those forms. You want to do it by state. So New York State, the Department of Health, click on forms, go to advanced directives. You can easily download it. Or I like the www.aarp website. It gives you a little more explanation to what the forms are, how to fill them out. But again, do it by state. Very, very important. I have a story about 2 terrific men that I knew, 80 years old, both diagnosed with lung cancer within a month of each other. Robert was a very educated man in Boston, and he decided to go into aggressive treatment right away. His doctors had all the latest medical treatment knowledge, very sophisticated, everything at his disposal. Lee said, okay, I'm 80 years old, I've had a good life, and if this is what it is, then this is what it is. So he decided to go home on hospice care. Robert was in and out of the hospital, and in a few months, they did the PET scan, and they said to him, you know what, the present chemo isn't working. They started him on another one, and again, he was in and out of the hospital many, many times, very weak, and he missed out on a lot of family functions. Robert died in December of 2011, a little over a year from his diagnosis. Now, Lee, although very advanced in his care and his process, was with us till February. However, Lee was home the whole time. He was making jokes. He was getting in and out of bed, in his garden. I want to make this very clear. I'm not saying that aggressive treatment is not the option, but I want you to know that you do have options, because I'm finding that it's not really clear. Choose whatever is right for you. This is about you and your family. There's certain parts in your life that you will remember. End of life is something that's videotaped in our minds. That's how you're going to remember the last days of somebody that you care about and that you've been with your whole life. It is so crucially important that you make sure those days are how you want them to be. And they can be positive. You know, death is a natural experience. Just like a baby coming into the world, we make special preparation and prepare for that. We need to do the same for people leaving us. Lots of love and support. So I do urge you to do your healthcare proxies, okay? It's very important. Have this conversation with your family. Open it up. This is about you and your loved ones. You have options, and you can decide what's right for you. Thank you. Thanks.
Are there any questions?
Yes,
Question, observation.
absolutely.
My family and I just went through a horrendous situation with my wife's cousin, where he lingered for 3 months after what should have been a routine operation, not here in Northern Dutchess, by the way, but down on Long Island.
Mm-hmm.
And all I could think of watching him lay there, unconscious with the tubes and the beepers and everything, we wouldn't let our dogs suffer like this.
We don't.
And so the question is,
Yeah.
do you see as a medical professional someday where we have a legalized situation where we're allowed to stop someone's suffering? You know,
I do.
euthanasia.
That's just, I mean, that's such a wonderful observation and
Yeah.
story. My son, when he was about 8 years old, said to me, because his grandmother on the other side had passed away, and she suffered. He says to me, how come we can put our dogs to sleep, but we can't put people we love? That's incredible from an 8-year-old. So yes, there are a few states now that do have it. Massachusetts in November, the law is coming up for dying with dignity. And, you know, they've done, and I'm going to do this in another talk because it's really important, the states that have it already have done tests on who comes to ask for it and who needs it. And it's not what people were saying was going to be the problem with it. People who are middle class, white, educated people get the medications, and I think it's a sense of control. I don't want to suffer. I have the medication if I need it, and I think statistically only half of them actually use it, if that. So there's a lot of good record material coming out to support that we should do that. And again, there's 2 doctors that need to sign off. It's not just one doctor is going to make that decision that, oh yes, your end of life. You know, you're going to have 2 doctors that are respected, and their license is going to be on, and integrity is going to be on the line. So it's going to be somebody who is at a terminal end of life, and that if there's going to be suffering, major suffering involved, they can choose to go a little earlier. And I think we absolutely should have that. I'm not sure why we don't at this point.
Yeah, I mean,
Yes.
just a comment on, to follow up what Joan is saying. I mean, the reality is, and I don't want to sound like an insensitive jerk, but part of the expense of healthcare has to do with people who just have no possibility of, say, waking up and just lingering for 3 months in a hospital, and then the government or insurance company sees a 7-figure.
You can't
bill.
ignore the financial
You
motivation
just
that's
cannot
happening. The
ignore
Wall
it.
Street Journal recently did a story called The Crushing Cost of Care. 76% was with the elderly, you know, in their last
Absolutely.
very small fraction.
Yeah, I mean,
I am not a money person, I'm a people person. And when I see the people suffering, like people on drips and ventilators and in hospitals, and being, I'm sure everyone has had a surgery of some sort or whatnot, to recover from that. If you do that to an elderly person, or if you put chemotherapy into them, it's almost an impossible course to endure at a certain point. So ethically and morally, we have an obligation to be honest about end of life, you know, and so that has to be addressed, and we have to find out, you know, and we have to just start saying to people, we got to do the right thing. But if we're not going to have the medical doctors address it, if we address it by doing our advanced directives, it's a no-brainer. Here, doctor, you know, oh, you know, these are your options. Oh, I already have what I don't really want anything. If it's, you know, terminal, end of life, I'd like to be kept comfortable and go home.
So
Okay.
in this case, there were no advanced directives.
Not that I'm aware of.
So this person is laying
He
there,
was young, he
from
was
my
unexpected.
perspective,
Yeah.
in
Young,
agony.
healthy, yeah, and it was unexpected, and every time they touched
Right.
him, it made him worse.
And the medical profession
Yeah.
or our culture doesn't have a process.
They're not going to do it. The process is, if you don't have that paper, you're going on it. You're going to get caught in a treadmill of Medicare until you pass away, and that's not the place to be for you or your family. Period. So do those forms, and they can be changed at any time. If you decide what you want today, guess what? If you want to change that at any time, you can. So it's not set in stone. But do them to have. It just is a feeling of security because it's your choice. Yeah.
And make sure you file them. You have to file them with the clerk's office.
You want to have, okay, and you want to have several copies. And you want to have a copy where you know where it is. Let's say, for instance, I had to go into the hospital. I want to be able to say it's right in that top dresser drawer. You can have your practitioner have one, make several copies. And of course, have your healthcare proxy have one.
Yep.
Okay.
Great.
Anyone else? Thank you very much. Good questions. Thanks.
Is that everything? David, are you pacing for a reason?
I didn't know if there was a gift today, so.
Oh, I got it right here.
Oh,
This is a gift for you.
thank you
These
so
little
much.
memo pads
Oh, I
to make
love
your
it.
notes, and
Perfect.
Here's a pen so you can make those notes.
Thank you very much, everybody. Thank you. I love it. This is great.
Is that it for the day? Did you notice that we're 4 minutes early?
You get a gold